Greetings and a warm welcome to all the dignitaries present here. I'm Rimpa from Clernet, serving as the allocated session assistant to ensure a seamless experience. Clernet proudly stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. It is with great pride that Clernet serves as digital partner for this event, and the focus of today's session is pre-eclampsia and update. Now, I would like to invite Dr. Meenakshi Sundaram, sir, a distinguished anesthesiologist and academic leader. Sir has served as Dean and DME at several government medical colleges, including Theni and Stanley Medical College, Chennai. He is a former national vice president of the Indian Society of Anesthesiologists and has held key positions including governing council member, president and state secretary of ISA TamilNadu state branch. To proceed with the session, over to you, sir.
Thank you, Clarnett. At the outset, I request our branch president, Dr. Munian, to offer his presidential remarks.
Good evening, all. On behalf of ISA Puthukkottai, I welcome all moderators, speakers, and faculties, and my dear friends for the online webinar conducted by ISA Puthukkottai City Branch, the name of Puthukkottai Bhudhan. Today we are going to talk about the critical aspect of pregnancy-induced hypertension. What are the pathophysiology of the pregnancy-induced hypertension, like vascular resistance, increased vascular resistance and vasoconstriction contribute to the pregnancy-induced hypertension. Endothelial dysfunction, which also responsible for the pregnancy PAH, and another one is placental factors, angiogenic proteins, which is a key factor responsible for the pregnancy-induced hypertension. What are the pre-anesthetic considerations? We have to evaluate the blood pressures and its medications. Whether our ideal blood pressure is 130/90, which can be controlled either with the drugs or without drugs. We have to assess, and also assess the airway assessment. Such PH patients will have the glottic edema, short neck, and obesity. We have to evaluate according to the airway assessment, and also fetal well-being, assessment of the fetal well-being and the gestation age. We have to assess. What are the anesthetic management? We have to keep all airway equipments and drugs and other things. Anesthetic choice which may be regional, which is the most preferred one, which can be either epidural or spinal. General anesthesia may also be indicated, which may be indicated in there is any failed spinal anesthesia or any clotting factor deficiency or any fetal distress. Today, we are going to talk, our speakers are very much interested to share their experience with all of us. One more thing, so I want to highlight our branch member and my respected professor, Dr.AL.Meenakshi is going to contest for president-elect, national president-elect for the year 2025. We have to support and elect our member and my professor for the ISA national president-elect. Let us listen in the online webinar. Thank you all, sir.
Thank you, Dr. Munian. As he was my postgraduate, he has extended his sympathy towards me. Right now, I request Dr. Kannan, our secretary, to propose the secretary address.
Good evening, all. I am Dr. Kannan, Secretary, ISA Puthukkottai City Branch. Successfully, we are conducting 22nd webinar of 2nd edition of Puthukkottai Bhudhan today. Today, our topic is pre-eclampsia and update. I welcome all our eminent speakers to our webinar. Last week, 11 June, we have conducted 21st webinar of Puthukkottai Bhudhan successfully. Last week, our topic was USG-guided regional anesthesia upper limb blocks. We have divided the topic into 3 subtopics. First subtopic is anatomy of brachial plexus. Second one is above the clavicle blocks. Third one is below the clavicle blocks. Our moderator was Dr. Sajis G. First subtopic, anatomy of brachial plexus, was done by Dr. Jose John Junior Resident, Government Medical College, Thiruvananthapuram, Kerala. Second subtopic, above the clavicular blocks was done by Dr. Neeta Jose, Assistant Professor, Government Medical College, Thiruvananthapuram, Kerala. Third subtopic, below the clavicle blocks done by Dr. Suvarna Kaniyil, Professor, Government Medical College, Manjeri, Kerala. And I should take some time to share our CME and workshop conducted Saturday and Sunday, that is June 14 and 15. We, Puthukkottai Society of Anesthesiologists, have made the great history in Puthukkottai with the grand success of our 2 days conference workshop on ultrasound guided nerve blocks and CME on June 14 and 15 held at Hotel MA Grand Puthukkottai. Our CME was inaugurated by Honorable Ministers of TamilNadu, Honorable Minister for Natural Resources, Dr. Mr. Raghupati, and Honorable Minister for Backward Classes, Mr. Siva B. Meghna, and our beloved brother, MLA of Puthukkottai, Dr. Muthuraja. Here is the history as inauguration of a city branch CME by 2 state ministers and 1 MLA. Honorable ministers have honored our past national presidents, Dr. Balakrishna, Dr. Chakrarao, Dr. Ranganathan, and honorable ministers have honored our ISA Puthukkottai members with lifetime achievement awards to former joint directors and our members, Dr. Suresh Kumar and Dr. Dharmar. CME was headed by ISA State President of Tamil Nadu, Dr. GP Kribaran, and ISA Puthukkottai President, as well as our organizing chairman, Dr. K. Munian. Welcome address given by me as ISA Puthukkottai branch secretary, as well as organizing secretary, Dr. P. Kannan. Introductory speech given by our academic chairman, Dr. AL.Meenakshi sir. Around 120 delegates have registered and attended our workshop and CME. Eminent faculties have arrived from various states. All faculties have nailed their topics in fantastic ways. Our ISA branch honored all faculties, organizing committee members, and doctors from various hospitals Puthukkottai who have supported in the best manners to our CME. Vote of thanks given by our treasurer, Dr. K. Hema. I thank all our faculties to our webinar, and our academic chairman for his kind support to always. We should support Dr. A.L.Meenakshi sir in President National Elect 2025. We extend our gratitude to you, sir. Thank you, sir.
Thank you, Mr. Secretary. Now it is my duty as a thematic address. I have to introduce the top class faculty to the audience. But before that, I was actually overwhelmed by the response which we received for the 2 days. That is 1 day ultrasound guided nerve block workshop and the 2nd day CME, because it is phenomenal. And we have invited for the workshop Dr. Nandini from Puducherry, Dr. Anaga from Kerala, Dr. Anil Kumar from Karnataka, Dr. Narmata and Meghna from Tamil Nadu. So all the states participated, and for the CME we have invited Dr. Chakrarao, Andhra, because it was omitted in that workshop. So we have invited him, and it was graced by 2 past presidents, Dr. Ranganathan and Dr. Balakrishnan, who are all Tamil Nadu, origin from Tamil Nadu, and national past presidents. And we have felicitated 2 serving deans in anesthesiology field, Dr. Kumuda Lingaraj and Dr. Amuda Rani. One is a private medical college dean, another is a government medical college dean. So as my secretary pointed out, it is heart-throbbing to see 2 state ministers and 1 MLA inaugurated the program. That is why the anesthesiology field has come to the limelight by the media. That is the reason why we have invited them, and they were so kind enough. We have fixed the inaugural function at 12 noon. But Honorable Chief Minister was arriving at the nearest airport exactly by 12 noon. But 2 ministers, they informed us we will come by 10:30. So the meeting was preponed. They were so kind enough, and they participated, and they have helped the anesthesiology field to come to the limelight. So I'm very happy about that. And we are continuing this webinar on every Wednesday, and the last webinar was on upper limb block. It was actually, all the presentations were very good, but we had some problem in the platform. So audio problem was there. And when it was brought to clarinet, now the topmost person is supervising this. Because for this 22 episodes, only once we had a problem, and yesterday it was twice last episode. Now the topmost faculty is supervising what is happening here from the clarinet side. And today we are very happy to see, because in India, if you say few reputed medical institutions, everyone will say it is All India Institute of Medical Sciences, then PGI Chandigarh, JIPMER, and CMC Vellore. They have their great separate reputations. Whether the faculty, whoever it is, by the name, they will be popular by the institution name. And it is a great coincidence, out of 4, now 2, that is CMC and the PGI Chandigarh are participating in this. Few more institutions which will come into mind is Lady Hardinge Medical College from New Delhi. Even the Lady Hardinge Medical College has participated in our program. All India Institute has participated in our program. AIMS participated in our program. That is how the Puthukkottai ISA chapter has invited the attention across the country. Now with the advent of clarinet, we are reaching the international population. And the youngest faculty here now, Abirami, usually we made a habit that we will introduce the youngsters so that they will be interested in future lectures. So Abirami would be Meghna, would be Ekta or would be Kajal Jain, I don't know. But she will come like that. She is native of Coimbatore and she did her undergraduation in Thuthukudi Medical College and pursuing PG in the prestigious Christian Medical College, Vellore. And this young faculty should come up in future also. But I want to inform the listeners, Dr. Abirami is waiting for a spouse. So let Puthukkottai Bhudhan be a matrimony for her. Many people, minimum 800 people will be attending, and it will go on YouTube recording also. Last time, because of audio problems, 650 attended. That was our lowest strength. So I wish her a beautiful future married life and the success in examination also. So 2 of your professors are here. I wish they should become your internal examiner so that you will get a walk through the examination. Thank you. And it will be followed by Meghna Madam. Meghna Madam is known for magnetic smile. So Madam is always bright and she will be curious. And Madam has so many publications to her credit because that is mandatory in Christian Medical College. And this time we are happy. Out of 4, 3 are professors. This is very difficult because usually 1 PG will be there, 2 assistant professors will be there, and 1 will be moderating. But here 2 professors are there, so we are very happy about the presence of Dr. Meghna Jiwanmall. Again, Madam, in addition to this, she is interested in cooking. So she will cook and others eat. Probably she may not eat. That is a technique behind that cooking hobby. So I wish Madam every success. And Madam, I thank you very much for having made your presence here. And it will be followed by a senior professor. One professor is senior professor is HOD. Madam Dr.Ekta, she is basically from Odisha but settled in TamilNadu. She is a great academician. She is a great academician. She is interested in pediatric anesthesia. She is interested in, but somehow Madam has selected the obstetric anesthesia to be there. And Madam is a WFSA pediatric fellowship. She is a course director. So she is a member of education committee of WFSA because WFSA, some Indians have made remarkable this thing. Madam is one among that, and she is a course coordinator for Tamil Nadu Dr. MJR Medical University. So it is our university. She is associated editor of Pediatric Anesthesia Journal and this Clinical Pharmacology Journal, and she is a AHA and BLS instructor. Then what else? She is a joint secretary for Tamil Nadu and Pondicherry chapter of IAPA, and she's a lead group in the PPSSG. In addition to all these things, she is a pious doctor, more spiritual. So if you see her in temple, you will exactly see diametrically opposite Ekta Roy, because I was fortunate to see that in Chidambaram temple, or else I would not have noted that. See, nobody can imagine that she is a professor of anesthesiology of high academic standards. She will behave as if she is a very innocent girl. going to the college. It will be like that. So it is diametrically, you have to see that is advantage. And madam is a great athlete. See, from her appearance, you can see that she's a great athlete. She's a swimmer. She's first, she says she's a sports person, woman. Then only she has become an anesthesiologist. So we should appreciate madam. And again, we had a problem. If two professors are there, who can moderate these two professors? One is a professor, another is a senior professor. So then we thought the only one person available to control these people is none other than Dr. Kajal Jain. See, the one word I will tell, Kajal Jain madam is the immediate past president of All India Obstetric Anesthesiology. She is a president of All India Obstetric Anesthesiology Association. So I need not say any other thing for obstetric topic. See, madam is very kind enough. Last time when we have performed the labor epidural pain relief symposium, we wanted madam to be the moderator. See, but madam was engaged in a family marriage function. So she said it is very difficult. At that time, Dr. Anju Grewal, who is the present president of All India Obstetric Anesthesiology Society, was moderating. Now we have two past presidents, All India Obstetric Anesthesia, and madam is a WFSA pediatric. So that shows the Puthukkottai Bhudhan is very much interested in the cream of academics. At the same time, we allow the youngsters also to come up like Dr. Abirami, and madam is a HOD of PGI Chandigarh. And routinely, I will have informal talks in all central government institutions. So all the people in Chandigarh, they appreciate madam recently taken over as a HOD. She is a founder and a co-chair for DM anesthesia and critical care. So that itself says how keen she is interested in developing the thing. And she's a founder of the first national academic body, STACS, Society of Trauma Anesthesia and Critical Care. It was previously called as ITAX. Even I was in a member in ITAX. But we will be only members, and madam will be the promoter, founder. It will be like that. So madam is, as I said, she is the immediate past president AOA. She is a president elect for Trauma Anesthesia and Critical Care Society. So she is not keeping quiet. So once obstetric is over, she is coming to trauma. If drama is over, again she will jump into another society. Societies are waiting, just like in a circus. People from this end will go to that end and will catch, and then only they will leave this bar. So that is what madam is doing. It is only dancing on the bar, and she is an executive member of Academy of Regional Anesthesia India, and she is Chandigarh Society of executive member, and necessarily she will be a faculty in all the conferences. And see, her publication and research material is outstanding, phenomenal. See, she is having that index. So many people, roughly more than 1,600 times her articles have been cited. So she has dedicated her life for obstetric anesthesia. And in addition to that, again, routinely people will say she's a good cook, but she's really a good cook. And she is interested in swimming, dancing, singing, everything. Everything. Even Dr. Ekta madam plays tennis. So many potential good extracurricular activities are suppressed by them for want of the academic caliber. So they devote their life for academic caliber for the youngsters like Dr. Abirami. So we thank once again for all the people to accept our invitation. And over to you, Madam Kajal Jain, Madam.
Thank you very much, sir. And that has been a very elaborate introduction of all of us. And very rightly, you have mentioned each and every point about us. So thank you very much. And we all know that today we are talking on a very important topic, that is preeclampsia. And preeclampsia has undergone so many changes in the definition, in the management, and the inclusion of the newer monitoring standards. And that's happening all over the globe because we know that preeclampsia is associated with the high maternal morbidity and mortality. So in order to understand why these women die, lots of researches have happened, and we all are very aware of significant trials which have taken. And the most important trial in this aspect is the MAGPIE trial, in which we came to know that magnesium sulfate is a savior for preeclamptics. So there are many other things which we will come across when we listen to our speakers, because the organizers have very beautifully, segregated it into 3 topics, and they have given the topics to the first speaker, which is like you go through the basics of preeclampsia, and then it's a slightly escalated topic, and then it's a further ahead. Dr. Ekta will take us over to the latest in anesthesia and preeclampsia. So I will ask Dr. Abirami to share her screen and start her topic, which is going to talk on the, as I said earlier, that she will be talking about preeclampsia and the physiological changes which happen during, or the pathophysiological changes which happen in a patient with hypertensive disorders of pregnancy. So Dr. Abirami, the screen is all yours.
Yes, ma'am. Good evening, all. Today I'll be talking about pathophysiology of hypertensive disorders of pregnancy. I'll be discussing on classification of hypertensive disorders and their definitions, risk factors of preeclampsia, and pathophysiology of preeclampsia. Coming to the classification by ACOG, hypertensive disorders of pregnancy are mainly classified into 4 main types: gestational hypertension, preeclampsia, and eclampsia. Preeclampsia is further divided into preeclampsia without severe features and severe preeclampsia, chronic hypertension, and chronic hypertension with superimposed preeclampsia. Gestational hypertension is defined as systolic blood pressure of more than or equal to 140 and diastolic blood pressure of more than or equal to 90 millimeters of mercury, which develops for the first time during pregnancy after 20 weeks of gestation, documented on 2 occasions at least 4 hours apart in a previously normotensive woman without proteinuria. Usually it resolves within 12 weeks of delivery, mostly occurs after 36 weeks of gestation and has good prognosis. 15 to 25% of gestational hypertensive women progress into preeclampsia and 5% of them progress into eclampsia. The definitive diagnosis of gestational hypertension can be made only retrospectively, as after it resolves within 12 weeks postpartum. Preeclampsia is defined as new onset hypertension that develops after 20 weeks of gestation with proteinuria or with evidence of multi-organ involvement in the absence of proteinuria. Proteinuria can be taken as 300 milligrams of protein in a 24-hour sample, or urinary protein creatinine ratio of more than or equal to 0.3, or 30 milligrams per deciliter of protein in a random urine sample, or dipstick reading of more than 1+. In the absence of proteinuria, multi-organ involvement can be taken, like thrombocytopenia with platelet counts less than 1 lakh, renal involvement with creatinine ratio creatinine value more than 1.1 or doubling of the baseline creatinine, liver involvement with elevation of liver enzymes to twice the baseline value, lung involvement with pulmonary edema, and CNS involvement with new onset headache or visual symptoms. The preeclampsia is further divided into non-severe and severe preeclampsia. Systolic BP of more than or equal to 160 and diastolic BP of more than or equal to 110 mmHg, along with proteinuria and involvement of end organs like headache, visual symptoms, epigastric pain, oliguria, low platelets, elevation of liver enzymes, and pulmonary edema, is termed as severe preeclampsia. Next is eclampsia. Occurrence of convulsions in preeclamptic women in the absence of other neurological conditions is defined as preeclampsia. Seizures usually occur in the second half of pregnancy up to 48 hours postpartum. Seizures can occur either antepartum, intrapartum, or postpartum. It rarely occurs beyond 48 hours postpartum. Next is chronic hypertension. Hypertension which develops before 20 weeks of gestation or that continues beyond 12 weeks postpartum is defined as chronic hypertension. It can be primary or secondary to renovascular diseases. Next is chronic hypertension with superimposed preeclampsia. It is defined when there is worsening of pre-existing hypertension, new onset proteinuria, or worsening of proteinuria in a previously chronic hypertensive women. There is higher mortality and morbidity in these group compared to preeclampsia. Next is risk factors of preeclampsia. Risk factors can be categorized in the following headings: First, demographic factors like advanced maternal age, more than 35 years, black race, genetic factors like history of preeclampsia in the previous pregnancy, family history of preeclampsia, or history of placental abruption, fetal growth restriction, or fetal death in the previous pregnancy. Medical conditions like diabetes, hypertension, chronic renal disease, obesity with BMI of more than 30, connective tissue disorders like antiphospholipid antibody syndrome, systemic lupus erythematosus are also risk factors. Obstetric conditions like multiple gestation, hydatiform mole, other factors like nulliparity, pregnancy conceived with the new partner are also the risk factors. Cigarette smoking is associated with reduced risk. Coming to the pathophysiology, placenta is the main pathogenic focus of the disease. Hence, the delivery of the placenta will lead to resolution of the symptoms and signs of preeclampsia. Preeclampsia is a two-stage disorder. First stage is the asymptomatic stage, which is called the abnormal placentation, called placental syndrome. Second is the symptomatic stage called maternal syndrome. Abnormal placentation is mainly due to defective trophoblastic invasion. In normal pregnancy, around 12 to 18 weeks of gestation, the endovascular trophoblasts of the chorionic villi invade the spiral arterioles of the invade the endothelium and the muscular walls of spiral arterioles present in decidua and the myometrial segment of the uterus, making them low resistance vascular channels. But in preeclampsia, because of defective trophoblastic invasion, only the decidual segments undergo the change, whereas the myometrial segments does not undergo the trophoblastic invasion, hence remain narrow and vasoconstricted, leading to placental hypoperfusion. This results in placental ischemia and hypoxia. Along with that, in normal pregnancy, there is immunological tolerance to fetal and paternal antigens. Hence, placental implantation occurs and continuation of pregnancy occurs. Whereas in preeclampsia, immunological maladaptation occurs and this immunological tolerance to fetal and paternal antigens are lost, leading to abnormal trophoblastic invasion. Also, genes for anti-angiogenic factors are located in the chromosome 12 and 13 are also involved in abnormal placentation. This resultant placental hypoperfusion and is leading to ischemia and hypoxia leads to the second symptomatic stage called maternal syndrome. This causes release of substances like cytokines, interleukins, and TNF-alpha and other inflammatory mediators into maternal circulation, leading to increased free radicals, causing oxidative stress in the maternal circulation. Along with that, it alters the balance between anti-angiogenic factors and the pro-angiogenic factors in the placenta, which further decreases the production of vasodilators like prostaglandin I2 and nitric oxide. These mechanisms causes endothelial damage and dysfunction, which causes the signs and symptoms of preeclampsia. So, normally in the placenta, there are angiogenic factors like vascular endothelial growth factor and placental growth factor, which causes vasodilation and vascular relaxation. But in preeclampsia, the anti-angiogenic factors like soluble FMS like tyrosine kinase 1 and soluble endocrine bind to these angiogenic factors and cause impaired relaxation and endothelial dysfunction. This endothelial damage and dysfunction causes the following mechanism leading to signs and symptoms. First, it increases because of the endothelial damage, it increases the capillary permeability, resulting in increased fluid in the interstitium, causing edema of the various organs. Next is the increased pressure response to circulating catecholamines and angiotensin II, causing hypertension. And also imbalance in prostacyclin and thromboxane A2 leads to vasospasm, further causes ischemia, necrosis, and hemorrhage of end organs, causing signs and symptoms. Later, the endothelial damage itself serves as nidus for platelet aggregation, causing microvascular coagulation, leading to thrombocytopenia. As a summary, in normal pregnancy, due to vascular remodeling and normal trophoblastic invasion, blood flow increases in the placenta, resulting in normoxia and normal endothelial function. Whereas in preeclampsia, due to abnormal trophoblastic invasion, placental blood flow decreases, causing ischemia and hypoxia, leading to increased angiogenic factors like SFLT1 and soluble endoglin, and decreased angiogenic factors like vascular endothelial growth factor and placental growth factor, causing endothelial dysfunction, which results in multi-organ involvement, multi-organ disease features, causing hypertension, glomerular dysfunction, and proteinuria. This also causes brain edema, liver edema, and coagulation abnormalities. These are my references. Thank you. I thank Dr. Ekta ma'am and Meghna ma'am for guiding me in this presentation.
Thank you, Dr. Abirami. Thank you very much. You have touched upon the relevant factors in a very simplified way. And as an anesthesiologist, so we must understand what is the basic pathophysiology in preeclampsia. And here I must make a remark that most of these women you had cited as the risk factors as like they are elderly, 35 plus, but sometimes we see them in a very younger age group, especially if they're having twin pregnancies. So just imagine the kind of changes which are going on in all body, because it's a basically disease of the endothelium. So wherever there is a blood vessel going, it will be affected, whether it's heart, kidney, your brain, or your liver. So whenever we are looking at these women, age should not be fooling us. So we have to be very careful that we understand that these women are in a progressive and a dynamic stage, where she had shown you even a chronic hypertension can get converted into chronic hypertension with superimposed preeclampsia. And why have they cut down such severe definitions of preeclampsia is that we used to miss these women because we were looking for some, rigid guidelines. So in that rigidity, we used to miss these women and they would die. If we have now classified them so intensively, we have seen that we are able to pick up these women much earlier and institute the therapy, which is simple, like control of blood pressure. And if that is not getting controlled, admit them. And if on admission they are still not doing well, then expedite their delivery, because ultimately delivery is the answer to all the problems. So it's very, very important to understand the pathophysiology, and especially understand the definitions which have undergone a sea change. No longer do we term it as pregnancy induced hypertension or PET, pre-eclamptic toxemia. We call it preeclampsia and preeclampsia with severe features. So just to revise, preeclampsia is, as she has said, a new onset hypertension beyond 20 weeks of gestation with the proteinuria. But if a woman is showing 140 by 90 BP and she's showing end organ damage, please do not think that she doesn't have proteinuria. So proteinuria, Abhirami, I would like you to again tell the house that how important is it to underline proteinuria, which we used to do earlier. So the newer definition has clearly told us that please look for end organ damage. If there are two end organs which are involved, like if the woman has come with a flushed face, she's complaining of a throbbing headache and she has a BP of 150 by 90, but she's not showing proteinuria at that point of time, you have to classify her as preeclampsia with severe features. You have to classify her. And this classification has changed only because we were looking for proteinuria, which didn't happen, but she was showing end organ damage. And then we lost her because she escalated to eclampsia, and then we were not able to take care of her in even in the best of centers. So preeclampsia with severe features needs to be studied again. When you go back, please read the textbook again. So preeclampsia and preeclampsia with severe features. Thank you very much for giving such an elaborate pathophysiological overview of this important thing. And next we will go on, since we have already come to know that there's a definition change and these women are at risk of deterioration anytime. So we must understand that we as anesthesiologists, how do we figure in? We have got a multidisciplinary role, not only for getting them delivered. We should be involved early on, because these patients are high risk surgical patients. Even if she's 20 years old, she's a primary gravida, she looks very, very young. You must understand that she is a high risk surgical patients. And we'll understand more from Dr. Meghna why they are so high risk surgical patients. Why do they need MDT teams? Why do they need an involvement of, if she's having severe features, she may even require, a cardiologist, a neurologist consultation, and you may need to even arrange for more blood, because they may be at risk of more bleeding because of their thrombocytopenia. So all these things are very, very important. And then on top of it, they may require enhanced imaging if they don't wake up after surgery, or they're showing signs of confusion and disorientation. So NCCT head, MRI, and then an intensive care unit. So all this fits into the armamentarium of an anesthesiologist. So a pre-operative checkup is very, very important. So over to you, Dr. Meghna, with this small piece of advice from my side, that how should these women be evaluated in the pre-operative period for surgery or delivery of baby.
Welcome all. Thank you to Dr. Sundaram for the kind introduction, and also to Dr. Ekta for giving this opportunity. So today I'll be speaking about the preoperative assessment of the patient which is coming to us for pregnancy-induced hypertension. So I have briefly put down the points under the headings as first, the knowledge and the awareness. Second is the initial evaluation. The third is the pre-anesthetic assessment. So in order to do a complete evaluation, we need to know in detail about the risk factors and also the clinical presentation and also the complications related to the particular topic. And for us, it's a pregnancy-induced hypertension and the whole preeclampsia syndrome, which I would like to say. And going to the next topic is initial evaluation. I have put down the point as in which I'll be covering the expectant management that is done by the obstetric team, because when we go as an anesthesiologist to assess the patient, most of the management, the initial management has been done by the obstetric team. However, we should have the knowledge about what needs to be done and what's missing. And also the timing of the delivery and also the preventive measures taken for the preeclampsia or the pregnancy-induced hypertension. And then coming to the pre-anesthetic assessment, which I'll be dealing in detail. So first, as Abirami had already told and described as different risk factors, here I have just highlighted the risk factors into high risk factors, moderate risk factors, and low risk factors. Now, these risk factors, we have to understand that this defines and governs as to low dose aspirin therapy will be required or not. So according to the ACOG guidelines, the high-risk patients, the recommendation is to start the low-dose aspirin in these patients. So these patients under high risk are history of preeclampsia, especially when they have accompanied adverse outcomes, multifetal gestation, chronic hypertension, diabetes type 1 or type 2, renal disease or autoimmune disease like SLE and antiphospholipid syndrome. When we come to the moderate risk factors for preeclampsia, it's mainly nulliparity, obesity, especially BMI more than 30, family history of preeclampsia, either mother or sister had a history of that. Socio-demographic characteristic like ethnicity, like most of the studies abroad have been done and they have found out that African-American ethnicity is more prone for preeclampsia and especially low socioeconomic status. So all these come under demographic characteristics, age more than 35 years, and personal history like any low birth weight or small for gestational age in the past, previous adverse pregnancy outcome, or pregnancy interval of 10 years. So these moderate risk factors, the ACOG recommends that aspirin therapy can be considered. Not recommended, but can be considered. The low risk ones are the previous uncomplicated full-term delivery. They don't recommend any aspirin for them. Now we need to know about the clinical features, as Abirami has already told about this, the preeclampsia without severe features and with severe features, as Dr. Kajal had highlighted about the proteinuria. So as we will be coming to the maternal evaluation, I would like to add that proteinuria is not to be done every time just to prove the diagnosis, and the end organ damage has to be focused mainly, apart from the blood pressure reading. So I will not go into the detail of this because Abirami has already taken this, and I will skip these slides. If you can see here, dipstick reading of 2+. So it is just used in other quantitative methods for proteinuria if other quantitative methods are not available in the center. So then we can use the dipstick reading of 2+ for proteinuria. And in the absence of proteinuria, we have already gone through this slide, so I will not take much time on this. Preeclampsia with severe features is also covered. Coming to eclampsia. Now, what is eclampsia? We need to know that if a lady has presented with a new onset tonic-clonic or focal or multifocal seizures in the absence of other causative conditions. Now, what are these other causative conditions? It's like any cerebral hemorrhage, or if in case the patient is already epileptic. So if these causative conditions, any cerebral condition is ruled out, and we don't have to diagnose that, but any new onset tonic-clonic focal or multifocal seizures are there, then eclampsia can be diagnosed apart from having high blood pressure and proteinuria. Usually it's seen in the second half of pregnancy and can last up to 48 hours postpartum. However, less than 4 weeks postpartum have also been reported, which is seen in 5% of the population. 78 to 83% of patients have premonitory signs of cerebral irritation in these patients who present with eclampsia. I will be coming to the definition of premonitory signs of cerebral irritation lately. And 20 to 38 patients do not show classic preeclampsia before getting a seizure. So that means 20 to 38% patient may not even present with high blood pressure or proteinuria, but they may directly come have seizuring or having some tonic-clonic seizures. So these are the Western figures. So we can still see that it's a very big number. Coming to the premonitory signs of cerebral irritation, when a patient presents in the labor room with severe and persistent occipital or frontal headaches, blurred vision, photophobia, altered mental status. So these are the signs of cerebral irritation which may precede the tonic-clonic seizures or impending seizure. There is an entity called as posterior reversible encephalopathy syndrome, PRES. And this is a constellation of various signs and symptoms, neurological signs and symptoms, which may include vision loss or deficit, seizures, headache, altered sensorium, or confusion. While we are doing the anesthetic evaluation, we should also be well versed with HELP syndrome, which is seen with the preeclampsia in some of the parturients. And the main symptom, according to the studies done, is 70% of the patient present with the main symptom being right upper quadrant pain, which is very common. And 50% of the patients presents with nausea and vomiting. And the other signs of HELP syndrome can be headache, visual disturbance. So these symptoms of eclampsia may be overlapping, but the main symptom they complain of right upper quadrant pain because of the stretching of the capsule of the liver. And this is because of all the edema and all the pathophysiology, which Abirami has already discussed. The main triad, which we will take the signs of HELP syndrome, will be hemolysis, elevated liver transaminases, thrombocytopenia. So platelets anywhere less than 1.5 lakhs should be always taken with a direct scrutiny and should be seen as the patient is admitted. We should see that there should not be a trend of decrease in platelets. So that has to be seen, especially when we see the signs of high blood pressure, proteinuria, any occipital headache or frontal headache. So if these signs and symptoms are also going on, so the obstetrician is supposed to keep an eye on the platelets, and we also should follow up the trend of the platelet counts. Elevated liver transaminases, the aspartate and alanine transaminases, these are two types. Now, generally, with all the liver parenchymal tissue, we see that the ALT is high, whereas in eclampsia and HELP syndrome, when they develop, very remarkably, the aspartate transaminases are high in the early stages of HELP syndrome. And later on, both ALT and AST will be elevated. Hemolysis is seen And that we can make out by the amount of LDH, which is more than 600 international unit per liter. These ladies are more prone for intravascular hemolysis, and that we can check by doing a peripheral blood smear, which will show the hemolytic picture. And in later stages, bilirubin can be very high, more than 1.2 milligrams, to see whether the lady is going into hemolysis or not. And HELP syndrome is considered to be very much associated with high mortality and morbidity. In the literature, there has been a lot of classifications for HELP diagnosis, and these classifications are called as Tennessee, Mississippi classifications. And I won't be going into great detail about it, but it is just a combination of all these lab tests along with the symptomatology of HELP syndrome. With this background of knowledge about the clinical features with which the preeclampsia with and without severe features, eclampsia, HELP syndrome, all these things can present, we focus on the initial evaluation. And this I have divided into maternal and fetal surveillance, hypertension treatment, seizure prophylaxis, and timing and route of delivery. This initial evaluation, we expect that has been done already, but we do need to check with the medical records. And when we do that pre-anesthetic evaluation, we should be able to go through that what has been done and what needs to be done later on. First is the maternal evaluation. In any evaluation, history is very important, and identifying the risk factors. And as we have already discussed about the risk factors, so I won't go into detail. Physical examination, checking the blood pressure, heart rate, and the systemic examination, the complete blood count where with platelet estimate, serum creatinine, LDH, and all the other tests, testing for proteinuria. Uric acid test is also done because uricemia is seen very much in the early stages of preeclampsia, and also it can help us to differentiate between the preeclampsia superimposed over chronic hypertension. And also the treatment history that the patient is on which antihypertensive, low-dose aspirin and magnesium sulfate therapy. Fetal evaluation is also very important, where on a regular basis, the mother or the pregnant lady is asked to take the daily fetal movement count with NST or the biophysical profile testing. Ultrasound evaluation for the estimated fetal weight and amniotic fluid volume also gives us the picture of how well the baby is doing, and Doppler ultrasound for fetal blood flow velocimetry when IUGR is suspected. So this we can always get from the records or talking to the obstetrician. Based on the maternal condition, we can also evaluate the antihypertensive approach, that is the expectant management which is given to the parturient. And this is mainly when the BP goes up or it's equal to 160 by 110 millimeters of mercury. So the treatment according to the ACOG guidelines is to start immediately or at least within 30 to 60 minutes of diagnosis. And the goal of this approach is to prevent maternal complications like cerebral hemorrhage, encephalopathy, cardiac failure, or myocardial infarction. Now, what do we aim at when we give the antihypertensive? And target systolic between 120 to 160 and the diastolic between 80 to 105. Dr. Ekta will be dealing with the management later on, but I would just like to highlight that this is just a brief examination that when we go to the labor room, this is what we are supposed to see, that the common drugs used are IV hydralazine or labetalol or oral nifedipine. And expectant management are usually done with oral labetalol and calcium channel blockers in our center. And the regimen is like, as it is written in the slides, you can see labetalol 200 mg orally every 12 hours, and then 800 mg over 8 to 12 hours as needed, with a maximum of 2.4 grams per day. Short-acting oral nifedipine can be added gradually if the desired blood pressure is not achieved with labetalol. And on an OPD basis, many of these ladies are also started on methyl lopa. As an emergency treatment, nifedipine, which is used, is of immediate release and 10 to 20 mg orally, and it can be repeated in 20 minutes if needed. And then we can give 10 to 20 milligrams every 2 to 6 hours. Maximum daily dose is 180. Labetalol 10 to 20 mg IV. The previous dose was oral, which I already told. And this is, we can give at 20 to 80 mg IV every 10 to 30 minutes. And constant infusion, also some people run of labetalol 1 to 2 milligram per minute IV. Hydralazine is something where usually it's given as an IV infusion and 5 to 10 mg IV, and then a 0.5 to 10 mg per hour the infusion. But if we are giving something like that, we need to have a beat-to-beat blood pressure monitoring in these patients and need to be admitted, and continuous BP monitoring has to be established. Coming to the seizure prophylaxis. Seizure prophylaxis, the recommended drug for seizure prophylaxis after the MAGPIE study has shown that magnesium sulfate has been a total game changer in these patients. And this is for the prevention and treatment of seizures in pregnant women, especially in gestational hypertension with severe features and preeclampsia with severe features or eclampsia. So there needs to be a therapeutic range which needs to maintain 4 to 8 milliequivalents per liter. However, patients with pregnancy-induced hypertension and preeclampsia without severe features, there is no consensus that MaxSulf needs to be started or it's recommended. But if they do, it doesn't take much time for a preeclampsia without severe features to turn into preeclampsia with severe features. That's why they have to be under strict monitoring. And this, there is, even though it says that there is no consensus in preeclampsia without severe features to use MaxSulf, if it changes to preeclampsia with severe features, so it's a very gray line where we have to keep the woman under strict surveillance and also under strict monitoring and decide about magnesium sulfate. There are places where magnesium sulfate may be contraindicated or unavailable, especially in conditions like myasthenia gravis, hypocalcemia, moderate to severe renal failure, cardiac ischemia, heart block, or myocarditis. Now, in these patients, other antiepileptics like benzodiazepine and phenytoin can be used. So this is the drug regimen of the magnesium sulfate, the IV loading dose of 4 to 6 grams over 20 to 30 minutes and maintenance dose of 1 to 2 grams per hour. If the seizures are still not controlled, 2 to 4 grams over 5 to 15 minutes if recurrent seizures are. There may be a patient for whom we might be called to secure the airway, and if they may come with no IV access, and in those scenarios where there is no IV access or there's a very difficult IV access, IM injections are preferred, 10 grams low dose and 5 grams every 4 hours. These are from the NICE guidelines that I have taken. Now, there is something where important points, which I thought it's very important to note in patients who are on seizure prophylaxis with magnesium sulfate. The important point is to know that the rate of seizure in preeclampsia with severe features with magnesium sulfate prophylaxis is 4 times higher than without severe features. So that means all these ladies tend to have more seizures, rate of seizures, than the ones who are without any magnesium sulfate. Now, if we use higher infusion rates of magnesium sulfate, I'll be coming to the toxicity, because as an anesthesiologist, we have to know when we are assessing in the labor room what all they're going through and how to assess the patient who is on magnesium sulfate. We should know that higher infusion rate increases the toxicity of magnesium sulfate. Accurate magnesium concentration is still not proven, that which is the exact concentration of magnesium that we have to maintain in our blood to prevent seizures. It is still not yet proven in any of these studies. And higher the BMI, especially BMI of more than 35, it also affects the dosage and duration, which is needed to reach the adequate circulating level of magnesium sulfate. So if a lady is more than 35 BMI and we are still giving the same IV regimen just to stay on the safe side so that we don't reach toxicity, there are high chances that she may not have adequate circulating magnesium level in her blood. And we should suspect that such ladies with high BMI tend to have seizures more commonly than the ones with the low BMI. Now, infusion rate of more than 2 grams per hour is associated with high perinatal morbidity. So if they are on a higher rate, we have to be very careful, and we have to raise our concern to the neonatologist and let them know about this. Adverse effects of magnesium sulfates are seen to be higher via intramuscular route rather than intravascular route, because the absorption and the distribution, the intramuscular route has no control. Once it's given, and it depends on the metabolism and distribution of the drug. Coming to the adverse effects of magnesium sulfate, main adverse effects that we as an anesthetist are worried all about is respiratory depression and cardiac arrest. And this can be checked by testing the deep tendon reflexes, the respiratory rate of the patient, how the breathing is, and also the maternal hemodynamics, like heart rate and blood pressure. So for this, we need to clinically monitor the urine output, respiratory status, and tendon reflexes. Now, deep tendon reflexes, why we are checking it? Because they are lost at a very high normal range of magnesium sulfate, that is around 9 milliequivalents. So if you remember my slide before, it's very close number to 8 milliequivalent, and once it reaches 8 and all, we have to be very careful. Not regularly that magnesium levels are done for all the patients, but depending on how much infusion rate, we have to be very careful. Respiratory depression also occurs at 10 milliequivalents per liter, and cardiac arrest happens at 25 milliequivalents per liter. Now, we have to measure the urine output to see, because most of this magnesium sulfate is excreted by the kidneys. And when the level is quite high, the first thing that happens is that they start going into oliguria and then anuria, and chances of acute renal failure is very high. And that's why the urine output is very helpful in this. The respiratory status, as I've told you, that it's a very potent respiratory depressor in higher doses. And the treatment of toxicity, when we come to, so once we have established the toxicity, what are we supposed to do if we are called? So it's like stop magnesium sulfate infusion and administer IV calcium gluconate, slow IV, 10%. The last point about this maternal evaluation was in the obstetric ward was that we have done the regular BP monitoring. The symptoms of worsening, we have discussed the severe pain, which changes, shortness of breath, we need to ask the patient. And the lab test, we need to raising liver enzymes and urine proteinuria. So urine documentation is more than enough. Subsequent documentation is not required. Continued serial ultrasounds have to be followed for fetal growth, and this is from the obstetric team and get the information. Frequency of tests may vary dependent on patient's condition. And without severe features, if the patient is doing well and with the antihypertensive treatment, he's okay, the delivery can be continued, but should not be taken beyond 37 weeks of gestation. So delivery should be planned by 37 weeks or before. When we come to preeclampsia with severe features and timing of the delivery, close monitoring of maternal and fetal conditions are must. Magnesium sulfate therapy should be considered. If there is a progressive deterioration of fetal or maternal condition, we have to stabilize the mother first. Delivery diagnosed at or beyond 34 weeks of gestation. In stable and maternal fetal condition, expectant management can be followed. Now, this is a very controversial topic because provided that we have those monitoring of the fetal condition, and also the neonatal outcome is beneficial, then should go ahead with expectant management, and we should expedite the delivery anytime if maternal or fetal condition worsens. This is a chart which is in short. I can say that we have admitted the patient, we have started the MAG-SULF and maternal fetal evaluation, and then the maternal distress. If there is, yes, then we magnesium sulfate and deliver. If no, and the pregnancy is more than 36 weeks of gestation, then we go for severe intrauterine growth restriction, whether it is there or not. If there is severe IUGR, yes, we give steroids. If no, then it comes to the number of gestation. If the gestation is less than 23 weeks, it's termination of pregnancy. If 23 to 32 weeks, then patient can be given steroids, antihypertensives if needed, and daily evaluation of maternal fetal condition, delivery at 34 weeks. If the patient is at 33 to 34 weeks, we can follow it, and then we can plan later on. Coming to the role of epidural labor analgesia. Now, this is a very important point in our pre-anesthetic evaluation. And this can be also one of the reasons why we can be called. So epidural labor analgesia, sometimes the patient might be on that, or what we might be called to put that. So what is the importance of epidural labor analgesia? Now, in these ladies, it reduces the neurosympathomimetic response. And this epidural labor analgesia, the mode of administration can be different. It can be intermittent boluses, or some institutions like to run infusions, like in our institution at CMC Vellore, we run a continuous infusion. And in countries, I have seen that there is a patient-controlled epidural analgesia, where they are given a button whenever they feel pain, they just press, and it's a patient-controlled analgesia. And this has been very commonly used in developed countries and widely accepted by the patients. However, infusions also have the same good outcome. The other uses of epidural labor analgesia is that we can use it for good post-operative analgesia, and also for a top-up if the patient is posted for a cesarean section, provided the epidural block is proper and bilaterally and working well. Coming to the maternal complications, I will be talking about the epidural later on when we do the coagulation part of it. So we'll be talking in detail as to what all things can affect and how can we decide about the epidural catheters. So talking about the maternal complication of preeclampsia, so there are quite many, and our main aim as anesthesiologists and obstetricians also is to prevent all these complications. It's like myocardial infarction, intracranial hemorrhage, congestive heart failure with pulmonary edema, postpartum hemorrhage, DIC ascites, pneumonitis, acute renal failure, as I told you before, and ruptured liver, cerebral edema, ARDS, and also patients can go on ventilators and can have VAP. Cerebral edema is quite common in these patients, and residual neurological deficits are also reported in patients who have had multiple uncontrolled seizures which are not treated. There are multiple fetal complications of preeclampsia we should be aware of, and one is this IUGR, oligohydramnios, placental abruption, perinatal death, non-reassuring fetal status. Preterm delivery is very common in these ladies. Respiratory distress syndrome in the neonates, and neonatal thrombocytopenia is also seen in a small percentage of babies. What are the preventive measures that we know of from literature? One is the regular antenatal care or checkup. There is no alternative to a regular antenatal care and checkup. Early detection by screening high patient and frequent exam. Balanced diet, quitting smoking. Calcium supplementation is a suggested one, not proven, but calcium supplementation has shown that there are chances of preeclampsia is less. There is insufficient evidence about presence of vitamin C, E, D, folic acid, in our diet, and also sodium restriction, fish oil, garlic supplementation. Will it reduce the risk of preeclampsia? There is very insufficient data on that. There are some drugs that are on investigative phase we should know of as for preventive measures. One is a metformin. The other one is sildenafil and statins, but we cannot use it on patients because these are all under controlled trials. The most recommended drug is low-dose aspirin, and we'll go to that. The low-dose aspirin, most of these ladies, when we go for anesthesia assessment, will be on this, and this is recommended for high-risk patient and considered for moderate-risk patient. The NICE guidelines tells us the dosage as 75 to 150 milligram per day, recommended from 12 weeks until the delivery of the baby. As far as ACOG is concerned, for them, the low dose aspirin dose is 81 milligram per day. I was just wondering whether they get the 81 milligram tablet or not. I'm not very sure of, but that's the recommendation of ACOG. So as Abirami has already told you the mechanism of action, I won't go into the detail. It mainly causes the inhibition of thromboxane A2 and thereby reducing the vasospasm. I will not going into the main detail of anesthetic consideration because Dr. Ekta will be covering this, but I just want to highlight few points which I thought in our evaluation it will be a must. One is the mode of delivery. So the indication for which the cesarean is posted is very important in order for us to decide what's the anesthetic plan and plan in our theaters, and that the obstetric consideration we have to take because the cesarean and vaginal consideration we have to do. Any type of worsening of fetal or maternal condition obstetric cause, we have to do the cesarean section, and vaginal delivery is done when there is no disease progression in preeclampsia without severe features. Regional versus general anesthesia also, it depends on the most preferred choice is regional anesthesia, provided there are no coagulopathy, thrombocytopenia.
Dr. Meghna, I think this Dr. Ekta will cover.
Yeah.
Yeah, so we
So
can.
this one I just wanted to tell about the epidural. It is like for epidural, we have seen that the platelet counts according to the ACOG guidelines, if it is less than 70,000, the chances of epidural hematoma is more. This is according to the 2020 guidelines that I'm talking about, and provided that they don't have any genetic coagulopathy. Coming to that magnesium sulfate also as an anesthesiologist, we all know that it potentiates the effect of non-depolarizing muscle relaxant, and also has to be cautioned with renal impairment and when given with calcium because it can reverse the anti-epileptic effect of magnesium when given along with calcium. Fluid restriction is very important in these patients. So 80 ml per hour according to the NICE guidelines, since these patients are more prone for pulmonary edema. Blood pressure control, as we have already seen it, and reducing CNS irritability by giving Maxel. Anesthetic evaluation, we'll come to the history, maternal hemodynamics, airway examination, ongoing treatment status, coagulation status, fluid balance, and assessment of the organ system involvement. So in history of the patient, we have to rule out the risk factors, which we've already discussed, recognize the features of preeclampsia with or without severe features, eclampsia, the premonitory signs, and HELP syndrome. The past medical history is very important in these patients, whether they are hypertensive, previous preeclampsia history, eclampsia, and also the diabetes mellitus. Treatment history, we need to know about whether are they on any antihypertensive, antiepileptics, or aspirin. And past anesthetic history, we need to know whether they had any history of difficult regional, like difficult spinal, difficult intubation, or any ICU admissions. Ongoing treatment which happens in the labor ward is seizure prophylaxis and blood pressure control, the epidural analgesia, the fluid management, and their nil per oral status when we are checking, because how much of fluid they have got in the labor room, that is also very important. And the epidural analgesia, whether it's working, and the level of the block. Coming to the examination, the general examination is very important in this lady. So the maternal hemodynamics are very important. So once the general appearance and sensorium we have checked, the maternal hemodynamics will include heart rate, blood pressure, oxygen saturation, temperature, and also the BMI. Systemic examination is a thorough checkup of the respiratory system, cardiovascular system, CNS, and abdominal system. BP measurement at all stages, this is very important for all of us to know, is that it requires an appropriate size cuff. The length of the cuff should be 1.5 times the upper arm circumference, or the cuff with a bladder that encircles 80% or more of the arm. Patient in an upright position with a 10-minute or longer rest, or in the left lateral recumbent position with the patient arm at the level of the heart. Patient should avoid caffeine or tobacco at least 30 minutes before the BP reading. So this is at all stages. Coming to the airway examination, apart from our regular airway examination of Malampatti, glass, the neck movement and the jaw movement, we have to focus on these patients are more prone for facial edema and presence of stridor. So difficult ventilation and intubation, they're more prone for that. And this can help us prepare adjuncts like bougie, videoscope, or fiber optic bronchoscope to be kept ready. Spine assessment for deformity and local infection or presence of epidural catheter, if any, and level of block. Depending on the category of cesarean delivery, this is the classification of urgency of cesarean delivery. I think most of us know about it, and I will skip this slide. Coming to the investigations and monitoring. Investigation and monitoring is, first is the complete blood count, which should include the platelet counts as we are following that. LFT has AST, ALT, and LDH. Renal function test focusing on the creatinine mainly and urea. Coagulation profile should be done if the platelets are less than 1 lakh. So it is not mandatory to be done for all patients, but since most of these patients' platelets are affected, PT with INR, PTT, and fibrinogen is advisable. Urine analysis and urine output monitoring is very required to see the proteinuria and oliguria, and also uric acid. As I said, hyperuricemia is seen in early stages, and blood group and cross match. We know all the detail about the placental growth factor, PIGF-based test, and this can be done. So in eclampsia, we will find the placental growth factor in a low range. Now, case-based requirement of arterial blood gas, chest X-ray, and ECG can be done. It is not done for all patients, and depending on the maternal condition, it can be asked for. And so is MRI imaging. And this is in discussion with the neurologist, if provided that her altered sensorium is there and it's ongoing and MRI imaging is required or not. Cardiotocography is always done for most of the patients who are admitted in labor room with this, which tells us about the fetal heart rate and uterine contractions. The assessment of the target organ system involved is taking into account all these symptoms and signs that I have discussed, along with the lab tests. Now, when we see that coagulation profile, sometimes the platelet count is less than 50,000. In that case, according to the ACOG guidelines, if it is less than 50,000, transfusion is required in these ladies because chances of postpartum hemorrhage goes up as soon as the baby is delivered. So these are the assessment of the target organ system. I won't be going into the detail as I've already discussed about it. Planning the anesthetic is always based on the fetal maternal condition, end organ involvement, presence of coagulopathy, thrombocytopenia, and presence of epidural catheter. This is the take-home message after this class of mine, is that thorough, up-to-date knowledge of PIH is mandatory for all of us. Awareness about recent recommendations and guidelines, multidisciplinary team involvement in decision-making, especially the obstetric team, the neonatology team, and also the anesthesia team. And later on, depending on the neurological status of the patient, the neurology team. Complete evaluation of the patient is a must. And patient should be also informed with, along with the relatives, with assurance, and also the pre-op optimization. These are my references. And thank you for your patient listening.
Thank you, Dr. Meghna. So in your lecture, we were concentrating on the pre-anesthetic assessment of preeclamptic patient. And just to give an overview and to revise your slides in just 2-3 more lines, I would just like to tell the audience that first and foremost, most of these women, they don't come in elective scenarios. They come anytime, and there is very little time for you to do a thorough pre-anesthetic examination, because most of us are still developing habit to see them in the labor room when they come. So Dr. Meghna has tried to tell you through her slides that be involved with the patient early on. And the reasons are not only that these patients are high risk, the reasons are that many of them undergo a C-section as the mode of their delivery. And there are many reasons for that too, because most of them, she has highlighted that they are fetal growth restriction. And when these women undergo induction of labor or trial of labor, the fetal distress happens very soon, and then they are wheeled in for section. So that is the reason you get very little time to do the pre-anesthetic assessment, which she has elaborated in the details. So must know the reason for cesarean delivery and why it is happening now. So many times you will be informed by your obstetrician that there is a fetal distress, and the fetal distress could be in response to refractory hypertension. So if there's a refractory hypertension, some of you have an overriding pressure from the obstetric and gynae to do the C-section stat. So please be mindful. She has already highlighted that there's a need for additional antihypertensives to control the blood pressure of the mother before you give general anesthesia. And this is very important, because hemorrhagic consequences of intracranial damages are very well known to us. So that is the importance of doing a pre-anesthetic assessment early on. And the second thing which I want to tell you is very importantly is that you must make a note of oxygen saturation. She had highlighted that in your PAC, look at oxygen saturation. So why is oxygen saturation very important? Because these women as such in pregnancy may show you 95% oxygen saturation because of the changes in her respiratory physiology. If she is having uncontrolled hypertension, which is an indication for a C-section, she may show a lower values, which you may not take so seriously, because these women are young and they are not showing symptoms of hypoxia or hypoxemia, say 92%, and she gets corrected with an oxygen mask. But this patient who is having hypertension showing a saturation of 92% would be very important to me, because she may be showing pulmonary edema in a post-op period. So that is the importance. You must make a note of oxygen saturation with and without oxygen supplementation. And the third thing she has already highlighted is the woman irritable? Please understand that these women are in a dynamic state. She may be deteriorating by an hour every time. So if she's irritable and she is not looking well, she has highlighted the role of early involvement of a neurologist, and and the possibility of sending the patient for a post-op NCCT head, and the possibility of arranging for a high dependency unit or intensive care unit. So these things are very, very important to understand. Similarly, if these patients are showing, in the pre-op, they're showing symptoms suggestive of cardiac failure, like pulmonary edema, and they're having some ECG changes. So you know that these patients are also very high risk. They will require inotropic support, central venous access, and even they may require ECMO. So you have to understand these things when you are doing PSC for a patient who's a preeclamptic with severe features coming at an odd hour in a remote place. So you have to understand this. Similarly, it goes for renal patients. If your patient is showing, rising serum creatinine and the values are twice the baseline, you not only need to adjust the doses of your muscle relaxants and other drugs, you also need to understand that this patient might undergo a renal replacement therapy in the immediate post-op period. So if is your college or your hospital or your facility equipped with this, or you need to send the patient, that decision has to be made in your preoperative assessment of a patient with preeclampsia with severe features. Similarly, I had also highlighted that if the patient is showing such low platelet counts, don't only be focused on epidural and spinal. She may also bleed, and you may require assistance from your transfusion medicine department. So these things have to be decided in the preoperative assessment only. And the last bit I want to tell you is, which Dr. Ekta will also touch upon, is that in the airway assessment, we have all understood now that women undergo a class change of Malampati even in a normal pregnancy. In preeclampsia, where you are already anticipating a difficult airway, and a woman who has labored will show another class change. So she'll become even more difficult. And all preeclamptics with severe VHS, they have very short labors for the reasons I've already told you before. Because they have got fetal growth restriction, and once they're put on oxytocin drip, the minute there's a fetal brady, they are brought in for cesarean section. So she would have labored less, but she would have undergone another class change of Malampati during her course of labor. So please be aware of these things when you plan your when you take your history and you prepare your theatre for these patients. With this, over to you, Dr. Ekta, for the next, in which Dr. Ekta is going to discuss about the anesthetic management and the challenges we face in these cases.
So, good evening, everyone. So, by now you must be wondering what am I going to do in next 20 minutes. So, I think that's exactly what we want to highlight here. The majority of decision making, the majority of planning actually happens at pre-op assessment period. So, I think pre-op assessment period is one of the most important phases for giving anesthesia. So, by now, when you heard Dr. Meghna, you can clearly see there's a wide spectrum of pre-eclampsia patients. They can be they can be with severe symptoms. They may be without severe symptoms. You may find it difficult to identify that this is a pre-eclamptic patient just one blood pressure value is not okay. You may have a patient who may be showing all kind of signs and symptoms as discussed by Dr. Meghna. So there's a wide spectrum. By now, you have understood it is not one organ disease. This is an issue with the endothelium, and endothelium is everywhere, wherever vessels there. It's not able to dilate, as Dr. Abirami mentioned. So basically, it involves the maternal syndrome involves any part of the body, and CNS involvement is one of the very scary stuff. So now I'm going to take you to anesthetic management, which is not going to be very difficult. One thing we have to say that consent taking in preoperative period is one of the very important thing in current era. You cannot take a consent of 2E if this is an emergency situation in a patient who is showing severe symptoms, of preeclampsia. Intraop multiple events can happen even before even taking and before even giving anesthesia. Eventualities can happen, so you have to be mindful of the correct consent taking apart from the proper preoperative evaluation, which has been discussed in detail by Dr. Meghna. So now, as Dr. Kajal said, we meet these pre-eclamptic mothers at different stages, and it's also very important to have a obstetric fetal medicine and anesthetic multidisciplinary meeting for any mother who comes to OG clinic and who shows high risk signs and symptoms, and in previous things like previous pregnancy she was preeclamptic. It's important to go and see that mother and figure out other comorbidities earlier than the complications. We normally, if we don't see them in multidisciplinary MDTs, then we see them mostly in our labor wards when we are called to either evaluate such a patient early because OG team has figured out that they are high risk patients, or also sometimes to give them analgesia because they are laboring and their sympathetic stimulation is happening. They're already in hypertension, and any sympathetic stimulation may not be very good for them. So these are the two reasons why you're called in. One, to see a very sick lady who they are not able to manage, and the other lady is who is requiring good analgesia. As Dr. Kajal mentioned, many of these ladies don't come for elective cesarean, but we do see few of them who are admitted in the ward, and with some either with severe preeclamptic symptoms or without severe preeclamptic symptoms. Now, the ones without without signs of severe preeclamptic symptoms can sometimes be in the ward, but the other ones are usually in the labor ward, undergoing strict monitoring or bed rest. Mostly they come in emergency, either as the deterioration of the condition of mother or because of fetal distress. Now, Dr. Meghna has in detail discussed, so I'm not going to talk too much about preoperative points, which already has been highlighted, but I will just in one slide say that whatever preoperative findings you have got in your assessment, you must optimize them if you have time. Lot of time, there's an emergency and you may not get that time, but still attempt to optimize blood pressure, even in the labor ward, before taking up to your theaters is a must. Giving them prophylactic cover for their brain safety with the help of magnesium again is important. Remember, you will get all investigations done. Your obstetric team would have already done it, but make sure don't get too fooled by hemoglobin number, which is on a higher side. They are in a volume depleted state and they are hemoconcentrated. So once you start giving fluids to them, they may drop hemoglobin faster than any other patient. And simple things we should never miss, like keeping these patient in left uterine displacement or in left lateral position, so that already patient who has got lesser preload should not further, you should not, or the mother by lying down in specific position should not further reduce the preload for herself. Preeclampsia, remember, is the leading cause of maternal morbidity and mortality. When we talk about preoperative hypertension, pre-cesarean hypertension, one thing I want to highlight before we even talk about cesarean section, the modality of delivery is normal vaginal delivery, if possible, unless there is obstetric and fetal indication. So that we must remember. We have already talked about the drugs used in preoperative phase. We have to ensure that blood pressure is at least to some extent under control and should not be very high, because intracranial hemorrhage is one of the major causes for maternal mortality and severe morbidities. So you have to be very mindful of this management. Now, you may think you are optimizing blood pressure, you have patient is preeclamptic. Don't underestimate the fact that this is a dynamic situation. The preeclamptic stage can become eclamptic stage at any point of time, even before you give anesthesia while shifting. It has happened to me personally, at least 2 to 3 events where the patient has thrown seizures on table while we were planning to give anesthesia. So these things you have to be mentally ready to prepare, and whenever crisis situation or critical events come, the standard management stays the same. You do your primary assessment and manage your A, B, C, D, and E. So here if the patient is throwing fits, you have to ensure you start some anticonvulsants, which is faster acting. Midazolam is a good choice. Probably these patients are already on magnesium sulfate. You can give another loading, but if they are not, definitely start loading for them, which is Dr. Meghna has already discussed in detail. Breathing, obviously, you have to start oxygen. You have to ensure BP is under control. And if it's very high, you must add some additional antihypertensive based on the need. Labetalol is a good drug, but if the BP is very high, you also can think about the direct vasodilators like GTN and NTG. Do not again miss POCUS. POCUS is going to be point of care ultrasound is going to be very helpful in these patients, especially in your pre-op assessment. You good to check lung, because these are vasodepleted. They are highly sympathetic stimulated patients. Their catecholamine is very high. Vasoconstriction is there, but they are volume depleted at the same time. Because of these pro-angiogenic factors and anti-angiogenic factors disbalance, they have a capillary leaking capillary. So what happens is you may not have too much of volume in your vessels, but you have a lot of extravascular lung volume or lung fluid. So doing a quick lung ultrasound in all areas is a good idea. In one sector, if you get more than 3 lines, or sometimes you can even combine all that. But I feel whenever you are in an emergency, one sector more than 3 lines or confluent lines, you can straight away say interstitial fluid is high. This patient has higher risk of going into pulmonary edema, intra-op and post-op, as Dr. Kajal also highlighted that saturation you should keep an eye on. This is one thing about your chances of pulmonary edema. This focus helps you guiding. Other thing is doing optic nerve sheet diameter. It is again a skill-based scanning. Might as well, it is a good idea to have somebody who is in habit of doing this scanning, because the differences are in millimeters. So the accuracy is very important. So if somebody knows how to do ONSD assessment, it's good idea to do it. And if it's high, then you know this patient has high risk for, is already in ICP, high raised ICP. And you have to be very careful while you're giving GA, if you're giving GA. And if the seizures also there, apart from this, then the plan probably will go towards GA. Then coming to point of care ultrasound heart, they are, afterload is high. They have high risk for diastolic dysfunction. They also have pressures are high. The LVH possibility is there. Volume is depleted. So these are a few things you can figure out which will help you giving your anesthesia later. Now, when I talk about analgesia, as we have touched already a bit about labor analgesia, the options are few. You have epidural, you have other systemic drugs, and remifentanil being around now also is one of the drug which is available, otherwise Entonox. Entonox is something which you can use for first stage of labor, but it's not good beyond that. Remifentanil, I have no experience, so I will not talk too much about this, but epidural is our old gold standard way to give analgesia to these mothers. And giving analgesia to these mothers, as I mentioned earlier, is very, very important, because we do not want further sympathetic stimulation already when the BP is on a higher side. While we plan for epidural analgesia in pre-eclamptic patients, we have to think about two things. What kind of presentation this mother has? Are there severe symptoms there, or this patient is, or this mother is without severe symptoms? So if the severe symptoms are present, you need to ensure, so in both the conditions, remember, it's a volume depleted stage. So you have to be careful about the volume status. Having said that, it is very difficult to have optimal fluid management in these patients. Co-loading is better than preloading. While you are co-loading also, remember, fluid restriction is a better idea than overloading the patient with fluid, because you, as we said earlier, they're already a high chance of going into pulmonary edema. Now, looking about the coagulopathy, as we already looked into the pathophysiology and also saw in our pre-op evaluation, there is a chance of coagulopathy. Platelets can be low in these patients. If the platelets are lower than a certain number, you know there is a chance of epidural hematoma. So if the patient presents with severe symptoms, the coagulation profile has to be done, or platelets rather, has to be done 2 hours before you plan to give epidural. You want to site in the epidural for these patients. Whereas if the patient don't have severe symptoms, within 6 hours, platelet numbers are fine. If your platelet number is, so remember, it is the trend of platelet which is more important than any absolute number. So when these patients who are already diagnosed with preeclampsia gets admitted into labor ward, the centers, certain investigations goes, as Dr. Meghna already highlighted. In that, you must look what was the baseline platelet. And as you are called in to provide epidural, you also will ask for platelet within 6 hours or 2 hours as per the condition of the patient. And always don't just look at the last number. Always compare the first and the last, or if they have done anything in between those numbers. This will give you an idea of deterioration of the patient. Now, if they have severe symptoms, I will highlight the fact that please don't stick to 6 hours. It is not 6 hours. It is less than 6 hours, which is around 2 hours. And different hospitals will make their policies around this number. So this is important. Again, another thing which Dr. Meghna already has highlighted, if your platelet count is less than 1 lakh, you have to do further coagulation profile like APTT, PT, and fibrinogen to ensure that there's the risk of hematoma is less. Now, I think I have kind of talked about this. Again, remember, platelet function also is affected. So number alone may or may not be enough. But here we have a role of TEG, but the facility, cost, all those things affect. So if you have to go by a generalized dictum, you can consider 50% of platelets work if whatever. So if your number is 1 lakh, definitely 50 to 60% of the 60,000 platelets are functional. So you can guide yourself. Whereas if so that's why we say platelet counts of less than 1.5 lakh becomes significant, and we must be careful while we place epidural. If I have to give you a number, that when you are putting this epidural, some numbers around 75,000 to a lakh is a good number for you not to have for anybody to have less chances of epidural hematoma. There is a big no if your platelet counts are less than 50,000. If your counts are more than a lakh and the fall in the trend is not so rapid, then you're probably safe. Yeah. So this is something like your black and white rule, never to do and when to do, probably is what I just highlighted. This also I have kind of said, mostly they come for normal delivery until unless there is an obstetric or fetal condition reason for that. Blood pressure alone is not the reason for cesarean section. So now I don't have much job actually. With all this background, now if the patient is stable, he is not thrown fits and you're lucky, you take these patients, take all precautions, make sure position is maintained. Before you take in patient, your theater should be very ready for two things. One, a difficult airway, which you anticipate because you have already assessed this patient. Dr. Kajal has very nicely highlighted. Pregnant mother itself is a difficult airway. This one is one step up. So you are dealing with a difficult airway. So you should be ready for a difficult airway. It is good habit to have a difficult airway cart where you don't have to run and collect things separately. And the cart comes in, a mobile cart comes into theater, and then you have most of the things available. When you choose, so though you may be planning for subarachnoid block, but your backup GA is always ready in obstetric theater, with the loaded drugs. So if you're planning for...
I think we can wind up fast because it's already 7:40 and there are some questions also.
Sure. So I'll just then say when to do what, and I'll just move on. So regional anesthesia, you can give subarachnoid block, you can give epidural block. Though theoretically it seems like epidural has a graded drop in blood pressure, so it may be may sound better than subarachnoid block, but most of the studies have shown subarachnoid block is almost same as epidural in terms of drop in blood pressure. And I will just skip this. Yes. So when we say subarachnoid block is same as epidural, remember your local anesthesia should be low dosed, 8 to 9 milligram bupivacaine, and you can consider two opioids. We practice only one opioid, which is hydrophilic morphine, but the literature suggests that you can use two opioids, low dose of lipid soluble fentanyl 20 mics and morphine 100 mics. Remember, co-loading, preloading in these patients have to be very, very careful. You have to be careful, and then if you want to err on the lower side. If you this you must remember, if you have to give, if by chance thinking that this patient is volume depleted, you give a lot of fluid acutely, what happens? Your ANP goes up. These patients have impaired renal function, so the clearance goes down. ANP causes diuretic action and smooth muscle dilatation, which adds on to hypotension. And also remember, this ANP causes, because of this dilation, increased capillary permeability. So basically, everything which you see in a preeclamptic patient has been exaggerated by this ANP. So acute correction of volume status is never recommended, never target to achieve right atrial pressure absolute normal. So again, as look for B lines. This is a dynamic stage. Keep doing your assessment again and again. This is again very important for all of us to understand that hypotension post subarachnoid block in preeclamptic patient is actually to a lesser degree than the normal pregnancy, and the reasons are these babies are less mature, they are small for age, so these mothers have less aortocaval compression. Preeclampsia actually is a arterial vasoconstricted stage. Subarachnoid causes sympatholysis and causes venodilation. So it has been proposed that there are different pathways. Then there are more potent vasopressor already existing in blood, and the vessels are more sensitive to these vasopressors. So these are the three reasons why you don't see too much of hypotension with subarachnoid block in preeclamptic mothers. So now epidural, be very careful. The drop in platelets is faster, trend is faster drop. Be mindful of the number. You cannot just go by one absolute number. Chances of epidural hematomas are more with a bigger needle. So that also can be a problem. And you don't get too much of advantage except for the fact that if you're putting catheter, post-op analgesia also can be given with that. Other thing is there's a lot of controversy around the addition of adrenaline into local anesthetics. So we have to be extremely careful. So there are two schools of thought. It's not proven that adding adrenaline causes hypertensive response, but we don't practice. Now, if the patient is because of any fetal distress or coagulopathy, or is so severe symptoms help his developing, you may end up giving general anesthesia, and this is high risk procedure for these mothers. So if you have chance, give regional. If you don't have any option, then obviously you have to give general anesthesia. And these are the indications: contraindication to regional block, post-ictal patient with obtended level of consciousness and recurrent seizures, presence of pulmonary edema associated with hypoxia, or patient doesn't give your consent. So when these patients come,
Can we wind up fast? It's 7:45. You've exceeded the time.
Yeah, I'll do that. So intraoperative monitoring, the standard ASA monitoring, remember you can go for invasive monitoring with resistant, in patient with resistant hypertension and heart failure. Keep doing your POCUS, very, very important. So you induce them with modified RSI, a lot of drugs for amnesia there. Etomidate seems like hemostable, cardiostable, but we use still titrated dose of propofol. Muscle relaxants, you can use suxamethonium or rocuronium double dose 1.2 milligram per kg. And don't forget to give analgesia. You must have neonatologist, a dedicated neonatologist to look after the baby, but you must add fentanyl. Otherwise, they are high risk of hypertensive response and ICH in these patients. And this has been already highlighted that there is laryngeal edema, and because of that, their airway is difficult. Laryngoscopic response has to be obtunded, and you have to have a clear plan about that. First and foremost is senior most should do laryngoscopy. If you have a chance, use video laryngoscope. The time of laryngoscopy should be as short as possible. That's the first point. Then you make sure the depth of anesthesia is good. And then you can add other drugs like beta blocker, short-acting beta blocker, lignocaine. You can add some more magnesium sulfate and labetalol and other drugs. But remember, short duration laryngoscopy is the trick. And if you don't do a good job with laryngoscopy, you may land up with intracranial hemorrhage, and which is one independent reason responsible for maternal mortality. I cannot go through this, but you must be well versed with difficult airway algorithm for obstetric mothers. As we said, muscle relaxants, these mothers are on magnesium sulfate. I will close, sir. Just give me a minute, because otherwise it will be half. So as these mothers are on magnesium sulfate, they potentiate action of non-depolarizing muscle relaxant, but there's no effect of magnesium sulfate on depolarizing muscle relaxant. And so gamma dex, so rocuronium, if airway is not too bad, may be okay to choose. Fluid, as we already decided and discussed, that you be careful. Crystalloid, colloid, give crystalloid, restrict fluid. If you need to give colloid, 5% albumin may be okay. Not many studies to support. If you have to give uterotonics after the baby is delivered, nothing is going to change immediately. Things will take time. So methogen is a high-risk drug because it causes hypertension. So be mindful, don't give that. Extubation is again a same challenge. You should not have hypertensive response at this point of time. So if you are okay, extubate deep. Otherwise, do a smooth extubation. Remember, these patients are full stomach. So it's very, very important. The baby is out. Things may take time to optimize. Patient is not stable yet. She has to go to ICU. And remember, preeclamptic patients will have severe symptoms sometimes after in the ICU. And these are the reasons why you want to shift these patients for fluid, for drugs, for magnesium. You need to continue magnesium for 24 hours in severe symptoms patient, but 12 hours in mild symptoms, and you need to give thromboprophylactic care. So few complications like edema, hypertensive crisis, PPH, oliguria, and renal compensation can happen. I cannot go too much in detail, but I will say pulmonary edema, identify early, manage as you do it in non-obstetric patient. Hypertensive crisis, you make sure if it's new onset hypertension, you need to start giving additional drugs like hydrolazine, furosemide, and nifedipine. PPH, very high risk. Make sure you give your oxytocin. The obstetrician should use mechanical methods to facilitate uterine contractions. Oliguria is multifactorial. If the kidney functions normal, just wait and watch. If kidney functions are not normal, then you need to start thinking about in terms of hemodialysis, and there are indications for that. Remember, there is no role of furosemide and low dose dopamine in this mother. So these are the indication for hemodialysis. Coming to help, I think most of it we have discussed. There is some discussion about corticosteroids in these patients, but it's controversial. no role of perioperative dexamethasone. Most causes of mortality in these mother is intracranial hemorrhage and cardiac failure. So you have to be very, very mindful of that. Remember, you have a baby also to look after. So be very mindful of what drugs you are giving. Remember, magnesium comes out in milk, but it's safe for newborns. Again, it is very important to know bromocriptine causes hypertension. And sometimes these baby may not be mother's side. So be very careful when you're using bromocriptine. Follow these patients up for a longer time, up to 6 to 8 weeks. And the take-home message, if I have to give one take-home message, it is a multidisciplinary management. Alone you cannot do. Pre-op assessment is the key. Intracranial hemorrhage is terrible and causes mortality. Sorry. Thank you so much.
Thank you very much, Dr. Ekta. Because of the time constraints, we had to interject in between, but I think the team has completely now talked about each and every aspect, and I think we can take the questions with the one closing remark, or one or two maybe. One is that, as you have said, MDT team, I would re-emphasize that ask for a senior anesthesiologist if you are not having one, because an extra pair of hands are required in these cases. Number two, when you plan your post-operative analgesia, be careful about prescribing diclofenac, because some of these patients have features suggestive of AKI. So do not write blindly paracetamol and diclofenac. And for tramadol also be careful, because the tramadol also has seizure threshold. So these things are very small, but they are very, very important. The rest, most of the things have been covered, but we are happy to take questions from our audience. So there are a couple of questions. We cannot, actually hear them out. So to the panelists, already Dr. Meghna has answered in the chat box, but she needs to speak it out, that how common is press in preeclampsia and how do we diagnose it and what is the treatment?
So
Dr. Meghna.
about the incidence of press, I'm not very much ready with the numbers because it's not mentioned much, because it is one of the suspicions that are made in the constellation of symptoms. So if a patient is having seizure, headache, altered sensorium, or confusion, press can be one of the diagnoses apart from patient going into eclampsia. And this question has been asked to me that how will we diagnose it? So the diagnosis can be done by the MRI, which can show presence of vasogenic edema and hyperintensities in the posterior aspect of the brain. Now, women who are particularly at risk of press is in the settings of eclampsia and preeclampsia. So if a patient has headache, altered consciousness, or visual abnormalities, so we can diagnose it as press if it continues to, the patient has continued to have even all these neurological symptoms post delivery, and the MRI can be done on to find out whether it's really press.
Yeah, thank you very much.
There is another entity called as reversible cerebral vasoconstriction syndrome, which can be confused with press. So these two are mentioned in the ACOG guidelines: reversible cerebral vasoconstriction syndrome and press.
So more important is to understand that in preeclampsia, which occurs in about 60,000 women worldwide, 75% of them develop neurological complications. And out of these, 0.3 to 0.6 per thousand women can develop eclampsia. So we just want to say a very small fragment can present with press, and which is clinically obvious, because any patient who has high blood pressure untreated is likely to have vasogenic edema of the posterior circulation because of the rich innervation. So that has to be very well known to the residents. And women who are showing signs of irritability and headache are the ones who would be having press. As such, press does not require intubation and mechanical ventilation, because most of these women would be having. Simple reduction in blood pressure helps, and observation of these women if they slip into a complication like, eclampsia is required. So that's the answer to it. So going ahead with the next is, how to calculate BMI in pregnant patients and is it reliable? So Dr. Meghna has answered it. Basically, you have some weight cutoffs in pregnancy. So weight cutoffs are defined in pregnancy, and anything which is, I think, more than 30 kg per meter square qualifies as BMI, as a high BMI, that is obese. And what is more important to know is that women who are obese to begin with cannot gain more weight in their pregnancy. Say if a normal patient can have a weight gain of 10 to 12 kgs, these women who are already high on BMI cannot have more weight gain. So those are the things which are very important to understand. There's a chart which you can go through. It's available on the internet as to how much weight gain a woman can undergo if she is already obese to begin with. So do you do coagulation profile for all patients coming for C-section? So Dr. Ekta, you want to answer that question?
Yeah, so we do platelets, definitely platelet counts. And if it's less than 1 lakh, we do APT, TPT, and INR. TEG is not available that easily for us. I mean, it's there in the institution, but we don't regularly do TEG. Fibrinogen also must be done.
Okay. So there, Dr. Muthu is asking, when patient presents with blurring of vision or any symptoms of PRES, can we give spinal? So we can give spinal. Spinals are mostly preferred and they should be avoided only if your patient is not conscious. If she has not come back to her pre-ictal state, like if she's drowsy, if she's drowsy, then we do not advocate spinal because she will not even give you, position. She will not even comprehend and she may be having some intracranial event. In those circumstances, spinal should be avoided. But if a patient has thrown fit and now she has become fully conscious oriented, she can be given spinal. So there is no reason why we should say that blurring of vision or any symptoms of PRES should be a contraindication to give spinal. If Dr. Ekta has anything else to add, she can tell
Oh,
us.
I completely agree. I completely agree.
Utility of dexmedetomidine in such patients. Having
No, in
I
what?
think maybe, ma'am, maybe another continuation is having high placental retention. That is super the have. It
okay,
is on
okay,
the
okay,
top.
okay, okay.
So I
Okay.
could not interpret Dr.
So
Naresh
this
very well.
question is not very clear. So what do they want to say? Is it a retained placenta, or we should not allow placenta because placenta should be delivered as fast as possible because it's a disease of placenta. And Dexmed has been tried now, but there are no studies to staunchly support its use in cesarean sections. There is no such evidence as of now for dexmedetomidine.
I'm totally unaware. I'm not able to understand the dexmedetomidine they are trying to say with spinal, or they are talking about GA. What exactly they are talking
No,
about?
that is not possible, ma'am, because the delegates are not allowed to interact because
Okay.
it will be time consuming.
So,
They
okay.
can only post questions, sir.
So
Okay.
at the moment, sir, if anybody is thinking of giving dexmedetomidine in general anesthesia before induction of general anesthesia, everyone has to understand there's a loading dose. It takes 10 to 15 minutes, and whether it will be really useful in emergency settings is debatable. So right now, if you want to use as a BP lowering medication, this is not the one. The ones which Dr. Ekta and Dr. Meghna have highlighted are the ones which have been tried, tested, and given by ACOG as well as NICE guidelines. So we should go ahead with that only. More important is to understand that do not intubate your patient at a BP of 160, 110 or more. These are considered as hypertensive emergencies, and any hypertensive emergencies, if not treated within 1 hour, can cause intracranial bleed. So residents get, very intimidated by the constant, buzzing of fetal distress, and a high BP. They will try to, intubate, and then they will cause unequal pupils. So I always say it is the mother which has to be taken in the highest regard. And at that point of time, you will not intubate because this is a hypertensive emergency. And one more point, This hypertensive emergency target cutoffs are different from the normal adult non-pregnant patients where we take 180, 110. Here we are talking about 160, 110 because of the neurological complications which are more profound in pregnant pre-eclamptic patients. So residents should be aware that 160, 110 is a hypertensive emergency to be treated within 1 hour, not catastrophically to be brought down because of the risk of abruptio placentae and hypoperfusion and adverse outcomes in the baby. So they should not even take one, they should try to bring it down within 30 to 60 minutes. Within 60 minutes, the blood pressure should drop. 60 minutes if you are in the labor room. 30 to 45 if you are taking the patient onto the OR. So be very careful about the blood pressure cutoff targets. It's 160, 110 should be viewed very seriously in a pregnant pre-eclamptic patient with severe features. So, sir, we are almost at on time.
So if moderator allows, we'll proceed with our formalities.
Yes, sir.
Yeah, thank you very much. Thank you.
I thank all the speakers for the inputs, the detailed data searching which they have done and brought out the right kind of material to the audience.
Thank
Madam, just like Saraswati, Lakshmi, Parvati, we had that lady power. 3 great people with the Bacha Abirami. So we are happy to see the woman power, Nari Shakti, अच्छी तरह निकला है अभी. I request another lady doctor, our treasurer, because ladies are very good treasurer. Our treasurer is very active, and she will never give money very easily. So she is a strict disciplinarian. I request Dr. Hema to propose vote of thanks.
Good evening, everyone. I thank you all for your participation in today's episode. I thank our academic chairman, Dr. A.L.M. sir, for your guidance. I thank Dr. Abirami, postgraduate, CMC Vellore, on your topic on physiology on PIH. I thank Dr. Meghna Jiwanmall, Professor, CMC Vellore, on the topic on pre-operative assessment on PIH. Thank you, ma'am. I thank Dr. Ekta, Senior Professor and HOD, CMC Vellore, on the anesthetic management of PIH. I thank our moderator, Dr. Kajal Jain, ma'am, Professor and HOD, PGI Chandigarh. Madam, we are honored to have you on today's episode, ma'am. Thank you. I thank Clarinet for your continuous support. I thank all the consultants, postgraduates, and colleagues for supporting us continuously in the webinar series. Thank you. Thank you all.
I request Clarinet to conclude the session.
Yes, sir. Thank you so much, everyone, for joining this session. Clarinet is really glad to have all these brilliant people together. So with all your permission, I'm closing the session for today. Thank you so much, everyone.
Thank you, sir, for the opportunity, sir. Thank you.
Thank you all. Thank you, sir.
Thank you, sir, and thank you, everyone.
Thank you, everyone.